This is HealthCall Online, a place for extended versions of interviews you hear on our weekly radio broadcast, the HealthCall Radio Hour. I think everybody agrees medical billing is a mess in this country. And what's interesting is it's a key point that a number of doctors have decided to step out of traditional healthcare models and go their own way. So it's really fed the growth of something called the direct primary care model. Lots of doctors would just rather not mess with insurance and treat their patients as members of their practice, paying a flat monthly fee for the health care they need. I call it the Netflix of medicine, and it kind of makes sense. That is one of the reasons that Dr. Jarrod Wiegman stepped out of his traditional medical career and founded Indiana Direct Primary Care. In full disclosure, I'm now a member of Dr. Wiegman's practice, and that entitles me to see him as often as I need each month. And also lets me drag him in front of the microphone from time to time to talk about this new movement in healthcare. So, Dr. Wiegman, thanks for being here.
Thanks so much. Don't have to drag me out. I love talking about this stuff.
Excellent. That's great. Just how much of the billing nightmare and hassle is the problem for doctors, and what did it mean for you?
It is a nightmare, really, because as a physician, we really want to be able to take care of patients. And when the focus for hospitals that employ physicians is really more the billing aspect of it, they tend to drag the physicians through their billing courses and classes. And it's not just billing, it's also something called coding. So you have to code the visit, and then based on the coding, if you don't code it correctly, you can't bill it. And so it's this game back and forth. So when we spend a lot of time trying to figure out, well, how we're going to bill this patient, this amount for this visit to make this salary, it becomes frustrating. And that's not what medicine should be about. So a lot of doctors are moving on to direct primary care, where we can control how things happen. We can control how billing exists because we don't have to go through insurance companies. We don't have to go through the big hospital systems. And we can really focus on the patients. And then we can provide the patients also with a lot of transparency and what the pricing is going to be.
Yeah, and that's certainly missing in the other side of the world. We'll talk about that in just a second. So each procedure gets a CPT code, which then goes to the insurance company for payment, right? So you've got different layers here. You've got coders and then billers, and sometimes they're combined. But those CPT codes can really be a confusing mess. And I've read, and confirm for me if it's true, that is a big part of the problem with billing errors and fraudulent billing sometimes.
Yeah, one of the things that we deal with a lot is trying to figure out the correct codes for the correct diagnoses. The insurance companies like to play this shell game where, every 3 months or so, they may change which CPT codes they pay for. So there are so many CPT codes out there for different things. So let's say you have diabetes, for instance. Under diabetes, there's, I don't even know how many there are, 50 or more different codes that you can get with that. And so you want to be as specific as possible based on the code and the diagnosis that the person has, or as specific as you can be, because the hospitals want you there because the more specific and the more detailed it is, the more they can bill for it. But the insurance company will play this shell game of, well, we're going to pay for it this month, but next month we won't pay for that one. You have to change it to this one. So what ends up happening is that you bill that same CPT code. The insurance company says, oh, we don't cover that anymore. And then that bill gets shot off to the patient. It's no longer covered. So all of a sudden their bill, triples in price. And patients don't know any better. They don't know that the code just needs to be rebuilt under a different number.
Yeah. And I have read that insurance companies are also pushing back against some CPT codes. So, and that has led to the creation of, am I correct on this, scribes who come into the exam room with you and help the doctor get the notes into the system right to make sure the right CPT code is applied so they can bill at the highest amount?
Correct. So when you look at those CPT codes, there are certain ones where you can really push the limits on what's going on with the patient. So, for instance, in the hospital, there's something called acute respiratory failure. So to me, and as a layperson, acute respiratory failure means somebody can't breathe. Somebody needs to be, maybe put on a breathing machine. But when you really look at the diagnosis code and what it's explained at, it's, a patient that requires oxygen at a certain level that didn't require oxygen before. And so Based on that, if you come in the hospital, you have pneumonia and you're not normally on oxygen, then all of a sudden you're on 4 liters of oxygen, that can be classified as acute respiratory failure. And the hospital likes to bill that because that's a really high payment coming back. So it's a little bit of a game. And so those scribes are there to pick up those extra little details.
And amazing. So all of those extra fingers in the pie, so to speak, do help drive the cost of healthcare. So in your practice, you just set your own costs. You're a business person, right?
So yeah, I'm not a business person at all. Very simple model that we have in direct primary care, and it's shared amongst the direct primary care practices for the most part. Direct primary care practices are very into helping one another and helping patients get into this system. So when you look at it, yes, we're quote unquote for profit, which a lot of hospitals are not for profit, but people get confused by that too. For profit doesn't mean I'm there to make $1 million a year. It means I'm there to cover salaries. It means I'm there to cover the cost of doing business. So basically, I looked at what the cost of doing business was for the model that we have, realized based on the care that we can give, what that would cost me. And basically, we just give that to the patients and say, here it is. This is, in our practice, is $99 a month. But that's, for the most part, all inclusive for anything we can do at our office. We don't, charge for every little piece. You talked about the Netflix of healthcare earlier. We don't want to be the Allegiant of healthcare, where you pay for your flight, but then also have to pay for your seat and your bag, and get on the plane first. And that's not how we want to work. We really want people to know what their costs are up front and be very reasonable about it.
The transparency thing, I've got a great example, personal example. My wife went to an appointment for just her hormone replacement therapy, an annual appointment. They took some blood to check for hormone levels. And so she got the invoice. The lab work alone was $718. And the insurance allegedly paid $618 of that, leaving us with just $100. Okay, fine. I looked at the CPT codes and then went out online because, I'm that kind of a nerd. I went out online and found a guide that told me what it should be billed. It was billed at way over what Medicare would pay. And I sent you those CPT codes. So we paid $318, well, the insurance company did, allegedly, for each of those hormone tests. I sent you the CPT codes. What would I have paid in your office?
Yeah, so after you sent me those, I was really shocked. And I was actually curious because those weren't tests that I run on a daily basis. So I looked them up. And both the tests were around $18 a piece.
$18 is what I would have paid?
Yep. So, $8.36, but for both.
Yeah, okay, fine. Oh, for both. Okay. So I ended up paying $100 out of pocket for tests that really should have cost somewhere around $30.
Yeah, and that's what I talk about in my practice a lot of times. I do have patients that have that background insurance, and oftentimes we talk about doing their lab work. And so most insurance companies, at least once a year, will allow for a normal physical and normal blood work based on that. Then after that, it's kind of up to the patient, their deductible, and what their copays are for those particular labs. A lot of my patients have $3,000, $5,000 deductibles. So when we get past that initial quote unquote free lab that they get the first time, I always give them the option. I tell them, through my clinic, these labs are going to cost you such and such amount, which is typically less than $50. And I would tell them, I don't know what your insurance covers. I don't know what my insurance covers for the most part. So you can take the chance of me, sending it to your insurance company and seeing what it is, or we can just pay the $50 out of pocket, through our system. That's your choice. And I'll be honest, most of them just choose to pay the cash.
Yeah, well, that's one of the reasons that I like your model is it's simple, it's transparent, and I don't have to spend time decoding an invoice. Let's talk about how this affects employers. And one of the big drivers, people associate healthcare with health insurance, and they're really not the same at all. But everybody beefs about the cost of health insurance as we receive it from our employers. How does direct primary care get into that and help solve that problem?
So there's a growing market for direct primary care within these practices or within these businesses. And it's a new concept. There used to be what we called employer-based clinics where, entire companies would hire a doctor to be and do their primary care for them. And they, their doctor, their employees would then go to their doctor. And so that,
Yeah, to the company doctor.
yeah.
Yeah.
And so that's evolved. That doesn't really exist anymore. To be honest, I don't know the history of why that sort of evolved away. But I do know that there are not a lot of places that do have that anymore. So what companies have done now with the way the healthcare prices and insurance prices are going up, they're looking at alternatives. How can they save money? And so one way to save money is to have less claims on their insurance. They know that they have to have insurance to attract employees, and it's important for them to also keep their employees healthy. So then how do they do that and have less claims toward the insurance? So what they found is when they partner with direct primary care practices, for a per employee fee, they have a known amount of money that they're going to come out of pocket every month for that. None of those claims go against their insurance, and 90% or more of the visits that their employees need go through that clinic. So that reduces significantly the amount of claims they have in their insurance. And people think, oh, well, what happens when I need to see a specialist care? And we've talked a little bit about this before. There are a lot of things that primary care doctors can do that they don't have to send to specialties. In direct primary care practice, we have so much more time with those visits that we can take care of a lot of those things. I have patients in my practice that were used to seeing their specialist 4 times a year. They often would tell me, I don't want to go back 4 times a year because I see the doctor once a year. They do some management decisions once a year. The other 3 times, they're really just following things, which I totally get. That's important. But those kind of things can be done in the primary care doctor's office. So if we can eliminate 3 subspecialty visits that goes against the insurance, that's less claims they have. The patients still get the good care that they need. And it also gives the subspecialist room to see new patients because they're so congested right now. If you want a new patient visit with a subspecialist in any big city that I've seen, you're going to look at 3 months or more.
It's crazy. And there are a lot of things that people just assume a specialist has to do that I know your people in your line of work, the direct primary care, are capable of doing. Joint injections with corticosteroids, and those things don't have to be done by a specialist.
No, there are certain things that we are trained to do that can easily be done in our offices that we don't have to send out. And oftentimes most people don't recognize that, but even if they thought about it, when you go to the orthopedist office, many times for those injections, there's a PA or a nurse practitioner doing those things. The doctors don't even focus on those small procedures anymore because they don't have time for them. Well, if you're going to do that, why not just stay with your primary care doctor who is more than qualified to do it?
Yeah, absolutely. So as if I'm a small business owner and I want to know more about this, I might be a little concerned, as you said, about specialist referrals. I don't want to have my employees to feel as though they're getting a substandard of care. Are there direct primary care specialists that you partner with? How would that happen if I did, for example, need to see a neurologist?
Sure. So direct primary care is starting to cross boundaries between just primary care and specialty care. It is a slower movement across the country just because, again, direct primary care, even though it's been around in primary care, has been there for a long period of time. The subspecialists are just starting to figure out how the model can work for them. So when we see it as it crosses across the country, what ends up happening is, like through my electronic medical record, for instance, which, as we went through the pandemic, everybody learned how to do televisits pretty quickly. So through the electronic medical record that I use, they've actually partnered with some of these people across the country. And through our electronic medical record itself, we can reach out to those individuals who do televisits in a direct primary care model, so neurology, for instance. The other great thing about that is, just like direct primary care, those prices are all transparent up front. So if it's a neurology visit, they may be $180 for that one visit. They may also, let's say somebody needs to be routine visits with the neurologist, so they see them monthly for whatever reason. They offer a lot of times a monthly fee that's lower than that as well. So these are all things that are coming across as doctors realize how good a model this is, how good it is for not just the patient, but also for the doctor.
So in that, let's just stick with that neurology example. Can the neurologist do what they need to do remotely? Do you act as their hands and eyes and interact with? Tell me how all of that comes out.
Yeah, so oftentimes we can do that and partner with them to, do exam features. A lot can be done, virtually as far as just visually, and a lot of it's just history taking, of course. But there are some exam features, obviously, that they cannot, do and pursue. So that's the things that the primary care doctor can actually help with. We can be their eyes and ears, in the clinic with the patient while they're doing the visit if that's needed.
Interesting. What else is out there? Take a look into the future. Give me an idea where you think this is all headed.
That's a tough question because direct primary care practices are unique from the aspect that we limit the number of patients that we see. And that is a pretty strict tenet for direct primary care to this point. The reason for that is we spend more time with patients, and the more patients you have in your panel, the less time you can see with each one of them. So when you broaden that and try to make it something much bigger than they sort of niche market, that's tough because there are a lot of patients out there that need to be seen and not enough providers for this kind of model. So is it ideal for the patients that can get into this kind of model right now? Yes. How do we make it a bigger system? I don't know the answer to that yet. And I think that's the question we have yet to approach. So, direct primary care may be leading to something else, but I think this is a good way to start.
How has it been as a doctor, a dad? I can contact you by phone, by text, whenever I need to. That's the deal we have, right? I send you a text at 9 o'clock at night if I've got a question or a problem. Are people being respectful of your time? Are you feeling any kind of boundary issues?
No, not at all. In fact, most times I will have to encourage patients to reach out to me because there are some that will end up going to an urgent care on a weekend, for instance, that I asked them, hey, why didn't you contact me? That's something we might have been able to save you some money and a lot of waiting time for. And they just don't think of it because it's a different mentality for people once they get into a practice like this. And when they do get to a point where they do feel more comfortable reaching out to me, they do so in a very respectful manner. I think they realize that, texting at 9 o'clock at night, I've always told my patients it's perfectly fine to do that, and I may be able to respond to them. But if it's 9 o'clock at night, it may be the next day. But again, for most people, that's much better than they're going to get in the traditional healthcare system. I've reached out to my doctor and not heard back for 3 days or a week, depending on what I was looking for. So if you need a refill and you're going to be, out, and it's easy to text that real quick, and you want to do it at 9 o'clock at night because that's when you remember, great. I'll get it in the morning and I'll send it in.
Are there any conditions that just really aren't appropriate? I'm assuming you're going to tell me cancer care. That makes sense. And obviously, you're not doing detailed surgeries. I'm assuming you can whack a suspicious lesion off of me in the office, and that's not a problem. But what might be a condition that is not appropriate? Or let me rephrase that question. What are conditions that you feel very comfortable handling that people might think are complex and need specialty care?
So I think there are a number of general health conditions that people have been conditioned that they need a certain subspecialist. So for instance, irregular heart rate called atrial fibrillation, that is something a primary care doctor can easily manage, although they tend to get shipped off to the cardiologist for that. Now, there are certain cases within that condition where they do need to see a cardiologist, things that are more difficult to control, and that's totally understandable. Same thing with diabetes. A lot of people will get shipped off to an endocrinologist for diabetes care, which is great. Again, it's perfectly manageable in the primary care doctor's office, but there are certain versions of those that are difficult to control where the endocrinologist is appropriate. So if you're some of those patients that exist in that realm where you're not just the typical diagnoses, but you have a more difficult to control version of that requires some subspecialty help, those are patients we can see and help manage their overall care because, again, all patients need someone to be their kind of homeroom teacher, so to speak, the one that, manages all the different subspecialties and make sure that, their heart doctor and their endocrinology are arguing over what type of, blood pressure medicine that they're on. Because I've seen it before where, the heart doctor will put them on, a certain type of blood pressure medicine. The kidney doctor puts them on a certain type of blood pressure medicine. They're the same medicine, but now they're taking two because one didn't know what the other one was doing. And so the patient didn't relay that information. So now all of a sudden they're at risk to be overtreated for something purely because there wasn't a homeroom teacher, somebody, a base for them.
Well, I'm glad to have you as my homeroom teacher, Doc. Thanks. I appreciate that. That is Dr. Jarrod Wiegman. He's the founder of Indiana Direct Primary Care. You'll find him online at indianadirectprimarycare.com. I'll see you in the office sometime.
See you there.